and this webinar will be recorded. So this webinar is is the first one in a series of webinars on the cost and cost effectiveness of child wasting treatment. It is organized by the GNC Technical Alliance and the CMAM Cost and Cost Effectiveness Group. My name is Bernadette Cichon. I'm a Senior Research Advisor at Action Against Hunger UK, and together with Emily Keane and Stacey Gobin at Save the Children, I'm one of the co-chairs of the CMAM Costing and Cost Effectiveness Working Group. Before we start, we'd just like to acknowledge the support of our donors and also the other organizations who have supported the organization of this webinar. So as a bit of a background, a couple of years ago, a few of us who are members of the Cost and Cost Effectiveness Working Group carried out a review on the available evidence of cost and cost effectiveness on wasting treatment. And what we found was that, first of all, there is very little information available on this topic. Over a 20-year period, we found only 11 cost effectiveness and 10 cost efficiency studies. And not only is there very little evidence available, but most of it was embedded in research studies, where it is often quite difficult to fully disentangle the research impact on cost and cost effectiveness from the normal programming. We also found that there were a wide range of differences in methods used, and that really the results are strongly influenced by context, which made it quite difficult to compare the results of different wasting interventions across the context. So with this in mind, the Cost and Cost Effectiveness Group was formed last year in 2021 as a sub-working group to the Wasting Global Thematic Working Group. And the objective of this group really are to raise awareness of the importance of the use of cost data for decision-making related to wasting treatment, to increase the availability, quality, and transparency of costing data, and also to share information related to cost and cost effectiveness of wasting treatment. We think that cost and cost effectiveness analysis is really important, particularly in the context of wasting, because it can help us which intervention to choose. It can help us optimize limited resources. And as most of you will know, to date, less than a quarter of children with wasting receive treatment. So it is really important that we increase the evidence base. And this is also important in the context of new approaches, simplified approaches being tested that really have the potential to dramatically increase coverage. So today, as part of our inaugural webinar, we will hear about how the cost data can be used in decision making. And then we are planning a series of subsequent webinar once a quarter, and there we will take a closer look at how we go about collecting and analyzing cost data. I will be facilitating the webinar today together with Stacey Gobin, who will be managing the Q&A. We have 4 presentations from Chloe Puett, Caitlin Tulloch, Blandina Rosalina Bate, and Eric Anderson. And for a bit of housekeeping, so please do go ahead and introduce yourself in the chat function. You can also use the chat functions for any technical questions. If you have questions for the speakers directly, please put them in the Q&A box. Your questions will then be either answered throughout the webinar or at the end during the Q&A session. If you missed it before, so translation is available by clicking the globe icon. We have translation in French, Spanish, and Arabic today. Right, so without further ado, I will hand over to Chloe Puett, who is an independent consultant and a researcher at Stony Brook University. And she will provide us with a brief introduction to cost analysis and how it is used in decision making. Over to you, Chloe.
Great. Thanks, Bernie. Next slide. So hello, everyone. I'm Chloe Puett, already been introduced. I'll be introducing the topic for the webinar today. The subject for my presentation is an introduction to cost analysis and its use in decision-making. And Bernie mentioned this generally, but I did want to explain that for the kickoff to this webinar series, we had in mind a non-economist audience who might be in a position to use and interpret cost data for wasting, or even commission a cost study for your own agency. So subsequent webinars will dig more into the technical details on conducting cost analysis, but for this first one, we wanted to speak very practically and provide high-level examples on how this data is used. Next slide, please, Bernie. So why is cost data important? Well, in the context of limited humanitarian resources, cost data provides a practical complement to data, for example, on program coverage and effectiveness. And this helps inform contextual decision-making to understand how feasible are alternative options for child wasting treatment, and how scale-up potentially can be financed in different contexts and with different budget constraints. Next slide. So when we talk about economic evaluation, there are actually several options that each serve a slightly different purpose. All economic evaluations include information on the cost of the intervention, and they combine that with different levels of information about what we get for that cost. So although it should be said that sometimes we just want to focus only on costs, if that's our objective, and there's other analyses like cost minimization and budget impact analyses that can do that. So first, at the top line of the box, cost efficiency analysis, which we'll be talking a lot about today, focuses on the cost per program output. It doesn't consider effectiveness of the program. Commonly for wasting, we look at the cost per child treated or enrolled in a program. And this tells you something about how many children the program was able to cover, but it doesn't tell you if the program was effective in treating those children. This approach is useful for understanding program coverage and the resource use needed to achieve that. Cost effectiveness analysis on the next line goes a step further and tells you how effective the intervention was relative to its costs. When we look at results of a cost effectiveness analysis, we have a cost per disease-related outcome, and we can compare among other programs addressing that same outcome. For wasting, this is usually the cost per child recovered from acute malnutrition. But sometimes with different objectives of our analyses, we may want to see how cost-effective is this intervention treating wasting compared with a broader set of programs treating different kinds of diseases in order to aid in priority setting. And so cost utility analysis gives us this information by using what are called utility-based metrics, like disability adjusted life years or DALYs, or quality adjusted life years or QALYs. And for any specific disease, you can calculate the death and disability caused by that disease, which you are preventing with your intervention, and then compare the cost per DALY averted with other interventions addressing different kinds of diseases. And finally, in benefit cost analysis, we sidestep any kind of specific disease-related measurement, and we compare the cost of an intervention relative to the monetary value of the benefits that it produces. And this, as you can imagine, involves a lot of assumptions, some of which are controversial. And this method is not very common in wasting treatment because the mortality that is prevented in treating wasting is inherently assumed to make the benefits outweigh the costs. Next slide, please. One more previous. I think it's 2 slides previous. So I'll go ahead and get started. It's the slide that has a picture on it. Why do we need more cost data? Well, we have a growing database on cost of child wasting treatment, but there's new approaches that are emerging, and cost is an important element to consider. The data we have so far has limitations. A report by Action Against Hunger and SAVE that Bernie mentioned from 2020 highlighted a wide variation in unit cost estimates, and it was hard to tell whether this difference in cost estimates was due to true differences in program costs or differences in methodology used. Comparing cost data across studies is limited by several factors, including the country context, the type of implementing organization, as well as the simple fact of what costs are included. For example, whether cost to households are considered, whether the study looks at additional costs needed for a new program or calculates total cost of the program, and what data sources are used. Often accounting estimates are higher than costs from an ingredients approach, where you develop cost estimates from the bottom up on your own. One practical example of quality concerns is not including the full cost of any health workers involved in treating child wasting, particularly if they're assumed to already be fully paid government workers. We need to know the additional time they spend in order to make sure the program is properly staffed, which has implications for effectiveness. Next slide. So as the evidence base grows, we need to keep data quality in mind, as there's some risks in ignoring it. Here we have depicted the vicious cycle of poor quality cost data. The first step is often to underreport costs to appear cheap or competitive. This could be at the proposal stage. This means that we have perpetually under-resourced programs, which results in poor quality programs. One simple basic step to avoid this vicious cycle is to ensure transparent reporting, documenting what costs are and are not included in an analysis to enable generalizability of cost estimates, to better understand generalizability. Next slide, please. So how is cost data used? In the most straightforward approach, unit costs per output or outcome can be used to understand affordability, sometimes relative to the effectiveness of an intervention. And this enables what is called benchmarking. And this involves setting a maximum or target price per output against which all programs are compared to help control prices, improve efficiency, and ultimately aid in deciding what makes sense to implement where. So this sounds very simple, but it's not always achieved in practice. A published survey of 6 major Action Against Hunger donors found that while all donors requested some type of what was called cost effectiveness analysis of field programs, the definitions of what this meant and the criteria used really varied by agency. And donors had a stated need, perceived need for capacity building on economic assessments themselves. So this is really an area where there's a lot of growth and learning that needs to happen. Next slide. So who are the organizations that use cost data? There's several different types of decision makers who have their own interest in cost data. We have CSOs or NGOs who compare the costs to improve efficiency of the programs that they implement. We have government that wants to determine the feasibility of implementing different kinds of programs in their country contexts. And we have donors who want to understand resource use of different programs that they fund. Next slide. In today's webinar, we'll have different examples from these decision-making organizations on how they use cost data. We'll have a CSO example from Caitlin Tillich from IRC, who uses cost efficiency data for internal decision-making and benchmarking. We'll have a government example from Blandina Rosalina Bates from UNICEF Indonesia, who used cost estimates and of wasting treatment and working with national and provincial governments for integration and scale up of IMAM. Then we have a donor example. This is Eric Anderson from USAID BHA, who considers the practical challenges and limitations of cost data from a donor perspective. Next slide. So having said that, I'll just ask you to enjoy the presentations and all the viewpoints presented, and I'll hand it over to Caitlin to discuss her experiences.
All right, hello everyone. I would love if somebody can just give a shout to confirm that they can hear me.
Yes, we can hear you.
Great. Thank you very much. I appreciate it. As Chloe said, my name is Caitlin Tillich, and I lead a team that does nothing but cost analysis all day, every day at the International Rescue Committee. Since around 2015, the IRC has really invested quite heavily in developing different types of cost analysis. And referring to that lovely table Chloe put up, we particularly do a lot of cost efficiency and cost effectiveness analysis. Cost effectiveness, whenever we have an impact evaluation that's measuring impact and outcomes, and cost efficiency in other cases. The goal of this kind of investment and work on cost analysis was really twofold. Number one is to help us respond to the kinds of donor questions Chloe mentioned. Certainly there are a lot of benchmarking efforts or interest out there. But I would say even more than that, it is for our own internal learning on what does it usually cost us to provide a CMAM program? How much does that vary? And I think the bigger question, why? We produce these analyses in collaboration with program teams. And I think that's a really important piece here, where we're pulling from data that exists in our finance and our monitoring systems, but where we're having these discussions about resource usage. How was the time of the health coordinator split across multiple programs? How was, are we sure that we've fully captured the cost of the staff salaries from the government health staff? It's really critical that we do this with, and to some extent for, our programs in the field. And that's partly so that our numbers are right, but also so that when we're looking at differences across these programs, across many countries, across many years, we can also hear directly from the people who implemented what was important or unique or interesting about the program. And while it's not directly incorporated into that cost efficiency number, that does help us keep some eye on issues of quality, issues of contextual appropriateness, and the other things happening in the world in which that program was implemented. So as of today, we have something like 20 cost efficiency analyses now completed of CMAM projects from 8 countries. And I think we plan to add at least another 5 a year for the next couple of years. There's some amount of variation in this, call it a sample for research purposes. Some of these are using the simplified protocol, others are using the traditional protocol. Some include CHW delivery of wasting treatment, others do not. And what's cool about having this data, I mean, number one is the lessons I'm going to show you in a second, but beyond that, our leadership has increasingly become comfortable with really sharing this and putting it on slides like you see right now. And that really helps us not only do this internal learning and planning, but also communicate and build consensus about what's going on. So we're really excited about this working group and the progress being made. Next slide, please. So as Chloe mentioned earlier, one quite important thing when doing these analyses is to ensure that the math is basically done the same way. People are counting the same costs, certainly that they're not undercounting costs in the name of looking cheap. And within IRC, we have a consistent costing methodology that helps us ensure that any variation in results, that final cost per child that we see, is not simply driven by different math. Somebody including our UTF costs here, but not including them there. Somebody including indirect here, but not there. So we're trying to control, make consistent the method that we use. But I really want to emphasize that having used a standard method, we expect to see variation in cost efficiency. Sometimes when we do this, people will say, well, have you controlled for the fact that, transportation costs are higher in country A versus country B, or that RUTF costs are higher, things like this? And the answer is no, because we want to see that variation. Understanding that variation is the whole point. And if we controlled for and adjusted all these things in our analysis, we would get some very boring results. So what our approach to this is, as I said, to do many analyses as possible. We've got this data set of 20 to see what the differences are. And this is my little blue diagram at the bottom. And then to start, I think, kind of sorting these differences, the difference in cost per child recovered or treated across programs, into 2 piles, as I think of it. One is trying to say, what's variation caused by contextual features? If I have an identical program or a very similar program and I can see it run in multiple countries, what variation do those contextual features create? And that kind of information helps lead us towards context-sensitive cost benchmarks. Cost benchmarks that take into account the inherent features of doing wasting treatment in a certain country. And I think with enough data, those can really be made a lot more tailored and precise and reduce the risks of inequity by imposing a single universal or global cost benchmark. On the other hand, we also see variation caused by the features of the program design itself. If I have many observations in one country and I'm seeing different cost per child, I can start to unpick that and say, do they do something different from one program to another that accounts for this? And that helps lead us to some best practices for design in our programs, once you've decided to work in a particular context. So this is all within IRC. I did want to give one shout out of imagine how exciting the world would be if my table didn't only have 20 IRC programs in it, but in fact, cost efficiency data from all of the many agencies doing these programs. And we do have a tool called Dioptra, don't want to dive into it now, but which is intended to help facilitate this kind of consistent cost efficiency analysis. So stay tuned for more about that, but next slide for now. So as I mentioned, we now have about 20 plus observations. And I've just gone ahead and shown you my little Excel sheet here. This is data from 8 countries. So we've got some good amount of variation, primarily in East and West Africa. We have, in some cases, only 1 observation per country. In other cases, we have up to 7, which is going to mean we can start to unpack some of the within country dynamics in a really neat way. Even things like, how does the cost of the same program in the same district evolve over time as conditions change or as the program matures? We have a pretty wide range of program scales, from maybe only 300 admissions up until around 10,000 children admitted. And correspondingly, the cost per child in the sample is very, very wide ranging. We have some programs that cost maybe around $100 per child treated and others that are almost $1,000. And I'm going to get into that more in a second. I do want to flag that right now, this sample, these costs do not include the costs of RUTF, because from IRC's perspective, this is most often donated. But we are working on going back, I think, and amending that so we have an analysis with those costs included available. Next slide, please. So if we start to do this sorting process I talked about, to see what are the features maybe of context that influence the cost per child. And I wanted to show you really the #1 graph that my team always produces when we have a big set of cost data like this, where we look at the cost per child treated compared to the scale of the program. So that's on the y-axis is the cost per child treated, as I said, ranging from about 100 up to 1,000. And on the x-axis is number of children treated. And what we're seeing, unsurprisingly, is that the more children you treat, the greater is the scale of the program. The cost per child declines pretty dramatically. Yes, Daniel, exactly as you've just said in the chat. I'm not sure this is a groundbreaking result. As an economist, this is somewhat what I would expect. But what's really interesting to me is that there is some amount of clustering taking place for the observations in different countries or within the same country. It's not perfect, they're not all together, but if you see the Mali observations, those programs, the yellow data points, are all on a certain range of the graph. The Yemen ones are clustered very far at the left. You can see what Kenya is actually quite tightly clustered together. And what we're taking from this is that there are really certain contextual features that constrain cost efficiency because they influence the number of children who are there to be treated in some sense within the catchment area of a health center. And in practice, what we're talking about is that within a given context, once you know what the prevalence of malnutrition is and the population density, there's a certain maximum number of children who are there to be treated with any kind of center-based program. And for now, all of these programs we're looking at are center-based. That means at a certain point, you're really starting to max out all of the children you can treat in a given area. But if I was to be perhaps in the country next door where prevalence was greater or population density was greater, there might still just be more children to treat. And that's going to be fundamentally a limiting factor on how low the cost per child can go. This is really interesting to me because it suggests not only costs vary by context, which I think we all knew, but in a predictable and specific way that would allow us to do this kind of context-sensitive benchmarking. And in particular, I think the key is to say, we're not judging the cost efficiency of a program in a lower density or lower prevalence place compared to one with higher density and higher prevalence, which is inherently going to be able to be more efficient than that other program ever could. So we're working a little bit on predictive work here to see, can we predict what the maximum cost efficiency is based on context and come up with those context sensitive benchmarks. All right, on the next slide, please. So that's about the constraints, the limits of how efficient a program can be. On the other hand, though, I mentioned we try and identify what are the programmatic features that drive cost efficiency. You know, once I have decided to implement a wasting treatment program in a good context, what choices can I make to not so much get the cost per child low, but make sure that I reach the greatest number of children with the dollars that I've got. And when we did a number of these analyses, you know, in addition to that spreadsheet, we have the full cost models that sit underneath. And after looking at enough of these, we started to see a structure emerging about what is it that drives the cost per child treated. The costs, as I mentioned earlier, are really driven by the number of health centers and how much it costs to operate a health center in that context. And then the number of children treated, this number of outputs in my cost efficiency metric, comes from a combination of the population density, the malnutrition prevalence, and then the treatment coverage. And what has really come through in looking comparatively at different programs in the same country is that the programs that achieve greatest coverage are the programs that tend to be the most cost efficient. And this is maybe not again kind of, you know, groundbreaking or shocking, but I think one of the really interesting lessons it's led to for IRC is that we need to be making additional investments in treatment coverage, in extending coverage through mass screening campaigns, through Family New Act, through things like this. And so, in fact, the way to get cost per child down is probably, within a given context, to be spending a little bit more, very, very specifically, on the kinds of things that get more children into treatment. And especially when we have data collection on what the barriers to treatment are locally, we can really tailor that. But this helps us make that, to some sense, investment case for why actually more money in the program will bring the cost per child down. Next slide, please. So that's all for me. Thank you so much. And I really look forward to hearing the Q&A and also hearing from Blandina about government use of this data in Indonesia.
Thank you, Kathleen. Good evening, good morning, and good afternoon, everyone. I'm Blandina, nutrition specialist from UNICEF Indonesia, Care for Wasted Children. So I'm going to share with you an example of UNICEF work in Indonesia on the costing analysis of the integrated management of acute malnutrition program. Next, please. Next, please. Yeah. So first of all, I would like to give you a brief overview on the prevalence of wasting in Indonesia. As you can see that basically Indonesia has the second highest children under 5 affected by severe wasting according to the latest report, in which 1 of 10 children under 5 in Indonesia suffer from wasting and more than 2.1 million are severely wasted. However, if you look at the number of severely wasted children receive treatment in a year, it's only less than 5%. So there is a huge gap between the burden every year and then the number of children receive treatment. Next, please. Next, please. So this is the target of global target and Indonesia target on child wasting. As you can see here that basically globally, the SDGs target to reduce the prevalence of wasting by 3%. And the government of Indonesia have a strong commitment in reducing the prevalence of wasting, in which the one of the indicator in the National Medium Development Plan is to reduce the prevalence of child wasting from 10% to 7% by 2024. And then the presidential decree on child stunting set an ambitious target to provide 90% of severely wasted children to receive treatment by 2024. And the Ministry of Health strategic planning target at least 60% of primary health centers provide the integrated management of acute malnutrition services by 2024. Next, please. Next, please. Yeah. So with that, basically, UNICEF Indonesia providing technical and advocacy support to the government of Indonesia in scaling up the life-saving approach IMAM program across the country's 34 provinces. One of the support the UNICEF Indonesia provide is conducting a costing analysis of the IMAM services, basically focusing in one these provinces in Indonesia in Eastern Part called Nusa Tenggara Timur NTT. So this is the first ever cost analysis of IMAM in Indonesia, since the IMAM program being scaling up nationally since 2018. This study is supported by an international consultant, LANI, and UNICEF IPRO, UNICEF Indonesia in partnership with the government of Indonesia. Next, please. So in conducting this study, basically we see that the involvement of the government of Indonesia, basically from the Ministry of Health and Ministry of Development and Planning, since the preparation of the study, including selection of the focus area and decide about drivers of the IMAM components to be including in the analysis, including the secondary data needed for the data analysis. Also, it starts from the tools development, where we try to contextualize FANTA tools to the Indonesia context, in which adjusted with the Ministry of Health guidelines on the IMAM that just released in 2019. Importantly, also the government involved in providing input from the preliminary result until the final report, including how to give recommendation on the implication of IMAM program implementation and policy implication based on the study results. Next, please. So the relevance of the IMAM costing to the scaling up effort of the government of Indonesia in scaling up the IMAM service, basically, this study is contextually grounded cost estimate, which is relying less on proxies and assumption from other contexts of program. So makes this cost assumption transparent and increases the reliability of the result. And also this costing tools facilitates budget impact analysis, increasing in which, for example, increasing the coverage or geographic coverage and may have implication on the costing of the IMAM. And then it's also provide cost data relevant for decision on resources on allocation needed to operationalize the scale up plans of the governments. As you can see in the first slide, that basically the government target to scaling up the services across the primary health center, at least 60% primary health center in this country by 2024. Next, please. So this is the drivers of the costing, basically. So we divide it into two components. The first one is the IMAM model itself, which consists of inpatient services for children below 6 months and also for children 5 to 59 months with complication, and outpatient care for uncomplicated cases aged 6 months to 59 months, and including the community outreach, which is screening, community mobilization, and default tracing or home visit. And there is also a driver on inpatient-only model. This is basically previously the history of the severely wasted children in Indonesia before the introducing of the IMAM approach, mostly being treated in the inpatient setting, either in hospital or in therapeutic feeding center or primary healthcare that provide the inpatient service. So we compare these drivers in terms of the inpatient-only model, where it's been provided the service for children 0 to 59 months with complication or without complication, and there is no outpatient care. And then there is also the component of community outreach, which is quite similar with the IMA model. Next, please. So the objective of this study basically to estimate the total financial envelope required to implement the IMAM in the sample district at the scope and scale outlined in the National Nutrition Plan. And it's also compare the cost of services delivery through IMA model with the cost of inpatient only care model for all cases, including those without complications. It's also identify cost drivers for the purpose of seeking opportunities to improve the cost efficiency. But the secondary objective of this study also basically to contribute to the global UNICEF exercise to provide accurate, standardized, and context-specific cost analysis for key severe wasting services in support of costed of the National Nutrition Plan. Next, please. So this is the result of the IMAM study. Basically, we can see that we compare the IMAM service with the inpatient only, and then the results showing that basically IMAM is 20-20% more cost efficient than the inpatient only model. So this is meaning that through IMAM approach, more children can be treated with the same level of resources using the IMAM model compared to the inpatients only model. This estimate will change depending on the geographic reach and treatment coverage. And then the second one also is showing that basically focus on increasing treatment coverage in high burden areas, consider the but at the same time also consider the trade-off with the equity. So this is showing that greater value for money with improved coverage in high burden areas. We can see that basically the government's target to improve the geographic coverage to 60% of the primary health care across the country. But at the same time, the study showing that basically the money, the greater value of money would be improve the coverage if it's focused in the high burden areas. And it is also, it's showing that basically there are three cost drivers, top three cost drivers of IMAM, which is, we can see the community outreach personnel, it's take about 28%, and then RUTF, and then supply logistic, and then it's followed with inpatient care staff training. But why the cost of the community outreach personnel seems very high? Because it is also reflect the value of the time of community outreach personnel, and then the outpatient care site staff training. If you can see, the cost is inelastic with the caseload. So as treatment increases, the proportion of total for RUTF also will increase, while the other two will decrease. And then the last one also, it shows that basically early detection may reduce the cost, because early detection the number of cases that requiring ITP care in this case will be reduced, and then it will saving costs in terms of the treatment that the child may need in the outpatient or in inpatient services. So this is the the sharing that I could share with you all today. Hope that will contribute to our discussion on how best to use the cost of data in our advocacy for the scaling up of the IMAM across the country. Thank you.
All right. Hi, folks. Real quickly, my name is Eric Anderson. I'm a nutrition advisor with USAID Bureau for Humanitarian Assistance. Both a colleague of mine and I, Dina Abramishan, we participate in the Costing of Wasting Treatment Working Group. And we've done so since rolling out the training for a cost effectiveness decision support tool a bit over a year ago. I've been asked to provide a bit of a donor perspective on the use of costing data and agreed to do so on the basis of providing sort of a working level snapshot, if you will, sort of where our team of nutritionists at BHA are relative to using this type of data. I make that distinction as I want to recognize the real innovators and technicians out in the audience today. And you've already heard from some of the real trailblazers in this space. And they're the reason why I and we at BHA have confidence in our ability as a community to continue evolving our practice and be able to reach more children in need with better results per dollar of funding available. What I hope to share is just a bit of how we at BHA have been thinking about this costing work, how we're trying to make contributions in this space and what we see as the road ahead. Next slide, please. So initially here, let's just get a sense of scale. In 2020, prior to the stand-up of USAID's BHA, or Bureau for Humanitarian Assistance, its legacy offices that came together to form BHA, those offices of the Office of Food for Peace and the Office of Foreign Disasters Assistance, they combined funding for CMAM programming with a total of nearly $500 million. With needs growing over the pandemic period amid rising costs, that number has continued to climb. With numbers that large, it's part and parcel of the humanitarian imperative, I think, that compels us all to constantly seek improvement and greater impact of the programs we fund. And when there's the opportunity to reach more children in need, we have to seize that opportunity. It's a simple equation, of course. It says that if we collectively can be more effective per dollar spent than all else equal, we can reach more children and ultimately prevent some measure of morbidity and mortality. These efforts within USAID BHA are driven by public health nutritionists and not economists or accountants. I make this point simply because while our interest in cost effectiveness, of course, is derived in part out of the need to be responsible stewards of taxpayer dollars, our primary interests are to see our funding make a greater impact for a greater number of those in need. Next slide, please. All right, so USAID BHA, and this was done really out of the legacy Office of Food for Peace, as I said before we came together as BHA. We funded a work stream in the Food Assistance Quality Review, or FAQR project, that was focused on cost effectiveness. So there were two main outputs of that work delivered to USAID BHA by Tufts University, the contractor. The first of which was a pair of field trials conducted in Burkina Faso and Sierra Leone. These trials looked at several variants of fortified blended flours, as well as ready-to-use supplementary food, or RUSF. And they explored the relative effectiveness and cost effectiveness of the products as part of a MAM treatment program in the case of Sierra Leone, or prevention of wasting and stunting program, as was the case in Burkina Faso. I encourage folks to go ahead and seek out those findings and have a look at those, as they certainly enhance our understanding at BHA regarding cost effectiveness based on product or commodity choice for these programs. The second piece of work that came out of that work stream on cost effectiveness was a tool called Facet for SNF. Basically, it's a food assistance cost effectiveness tool specifically for specialized nutritious foods. That tool was developed to provide a resource for those designing or managing programs that are set on treating or preventing wasting, as well as stunting prevention programs. Its design might be compared to sort of an online mortgage or investment calculator, in that it's an interactive interface, allows users to populate a host of parameters and generate an output of overall cost and cost effectiveness. The image on the slide is an example of an output a user might see while using the tool. The tool is constructed with a host of resources to support the user in identification of the data needed to carry out the costing, and links to available evidence on recovery rates, relapse, coverage, etc., to complete the effectiveness side of the calculation. I encourage folks who are not familiar with the tool to have a look at it, and note on the site with the tool itself are links to recorded training videos and user guides, as well as training manuals. Next slide, please. So as a byproduct of that tools development, our work with Tufts University helped us at BHA to develop a deeper understanding of the challenges in costing analysis. In building a decision support tool to aid our partners, and through the first round of trainings that allowed for significant dialogue with partners and potential users, it became quite clear that there are challenges to obtaining accurate costing data for many of the elements, whether they be commodity, warehousing, storage, transportation, labor, and any other number of cost fields. Operational partners often stated that while much of this data becomes available by way of carrying out a project, it can be difficult to get that data at the design stage when a decision support tool might be most useful. Cost data regarding logistics related to the supplies and commodities needed for these programs is often managed apart from the cost data associated with the other elements of the program. Sort of think of this as like your operations or your logistics people often sit quite distinct seating in an organization from your public health nutritionists and CMAM managers, for instance. Additionally, so much as cost-effective analysis can influence programming or product choices, many times there is limited flexibility in how programs are to be run. Many of the decision points that can potentially be modified that would affect cost effectiveness are dictated to service providers by way of decisions at the cluster level or by ministries of health. This can include length of stay, program duration, commodity choice, dosage. It's, and any other number of variables that are sort of dictated to the people that run the programs. Additionally, wasting programs are often not run in isolation, and thus attributing costs to different programming activities can be quite challenging. Another major challenge that seemed to be relatively unresolved is the nature of many wasting treatment programs that may see the specialized nutritious foods themselves provided by a UN agency like UNICEF or WFP, and or through the Ministry of Health with an NGO as the service provider to carry out the program utilizing those commodities. And we saw this sort of in IRC's wrap up where they were forced to sort of leave the RUTF costs out of the analysis. This cost sharing really greatly complicates the ability to conduct effective cost analyses. And it's, in our opinion, it sort of has stunted our collective ability to learn in this space. Next slide, please. So on our nutrition team at USAID BHA, it seems that a more sophisticated understanding of costing data and cost effectiveness analysis resides currently with a small host of our partners. Some have presented today, and they highlight some of the more promising work going on in this space to understand costs and how that understanding can inform the programming choices we make. In a world of finite resources and overwhelming needs, we'd of course like to see our partner organizations better understand the dynamics at play and the influence of their decisions on the cost and the effectiveness of the programs. We're not just looking at ways to drive down costs. Increasing the effectiveness of programs, of course, creates influence in the same direction as lowering those costs. If we borrow from the diffusion of ideas or technology adoption folks, the embrace of this costing and cost effectiveness data in program design, we think sort of still resides on the left-hand side of this bell curve. It seems to still sit with the innovators. Perhaps they've been able to pull a few of the early adopters along, but really there's a lot of work still ahead to get a community to embrace this costing approach. We want to be part of making utilization of this type of data more commonplace and able to inform the practice of both wasting treatment and prevention programs. And we believe that doing so will help us to fund programs that will have the capacity to reach more kids in need. I'm sort of emboldened by this webinar as the kickoff to a series of webinars. I look down at the number of attendees, and I think this is all sort of an excellent signal of interest in the area, and we'd like to continue to be part of the process of creating a greater knowledge base and improving the overall fluency, if you will, of costing in terms of its terms, its methodologies, tools, the inherent limitations, et cetera. And we certainly continue to seek out opportunities to support this community in the development and dissemination of costing tools and analyses as a means of through which to improve programs. So that sort of concludes my moments. Let me pass it over to Stacy, I think, to move us into the question and answer. Thank you.
Hi, thanks, Eric, and thanks everyone for the great presentations. I've just turned on my video and I hope everyone can hear me. I will assume yes unless I get a negative response. Throughout the presentations, excuse me, throughout the presentations, we have had the Q&A box open and have been answering questions as they come through. So we do have some of those answered and everyone can take a look at those, or we can prepare some follow-up after the webinar on presenting some of those responses. We do have 2 current unanswered questions that we can pose to the panelists at this time that have yet to be answered. And I think more are starting to trickle in as the presentations have ended. And please, all participants, feel free to add in your questions at this time if you haven't had a chance to do so yet.
Stacey, this is Chloe. I just wanted to share a few reflections on the slides and sort of like overarching themes before going to the Q&A.
Great. Okay, go ahead, Chloe.
Yeah,
we can do that while everyone's popping in their questions.
Sorry to interrupt. So yeah, just sort of digesting some of this information that everyone has shared. A few points emerged that I thought were useful as we move forward, both in this webinar period and in the future. So one thing that I thought was really interesting is the importance of context. I know this is sort of, for people who are, who have been following costing analysis, we all know that costs are context dependent, but here we saw some real specific evidence on things like local burden of wasting and local program factors that influence coverage, for example. And this sort of reinforces what we have been discussing for a while, that we need to be careful about interpreting cost estimates across contexts, even though that's certainly a goal and of interest to everyone. And I'll have something more to say on that in just a minute. But also one thing that Caitlin mentioned and that Eric followed up on that I think is really important is that when we talk, oftentimes when you hear the word efficiency, cost efficiency, you think cost reduction, cost control, whereas what makes a lot of sense that we've heard today is that sometimes spending more, maybe in a targeted way that is going to really influence program coverage and quality, actually improves cost efficiency. And so we need to think about where to invest and what investments make most sense, not just about controlling costs, but being strategic to help improve, if you want to say, the health of the programs that we implement or how well these programs work, and not just starve them and starve the quality that they're able to produce. Next, we hear in general a lot about the importance of cost effectiveness evidence and how cost effectiveness is a really important evidence base to build. But today we saw the importance of cost data alone. And I think that's something really important to keep in mind, that there's plenty we can learn with costs and outputs, and we should promote growing this kind of evidence base too, and not just focus on cost effectiveness to the detriment of this other very useful part of the equation. And finally, something that I sort of laughed to myself as I was hearing the different presentations, particularly Eric's presentation, is that what can seem like technical details, people who have been working in the costing field for a while struggle with things like incomplete costing data and determining shared costs between different implementers and getting different partners to share their cost data. These are things that seem sort of like a sort of technical detail, but they actually inform practical decision-making and are obviously important to get costs right for individual components of a program. And as Caitlin said, this tells you a lot about how a program is implemented, contextual factors that drive the cost. So obviously important to collect. And so I think that this suggests that even despite the context dependency of costs, that it's also really important to have an official minimum standards and shared approach as a field for these technical pieces to help set some guidelines for how to estimate them. So we have this context specificity on one hand and a real need for some general guidance across contexts on the other hand. So that's all of my thoughts, and happy to open up to Q&A now. Thanks a lot.
Great, so much, Chloe. I think we do have some outstanding comments in the Q&A box for you, Eric, particularly since you were the last presenter and we haven't maybe had a chance to get through all of those yet. So maybe I can verbalize some of those to you at this time, and then we can see as others come in. I think there was a really nice question from Daniel Takea, who mentioned that, or asked how cost efficiency or cost effectiveness perhaps, and how this is done for programs who are often disrupted due to security or supply chain breakdown. I think this is a question around the use of economic evaluation methods in non-permissive environments or in areas of insecurity or times of supply chain breakdowns and things. So this may be something that you could speak to a bit, Eric, or even others on the panel who have, of course, mentioned these contextual differences and how they impact the work that we're talking about.
Yeah, I'll just say a few words and I'll try and punt it to colleagues who've done more of the in-depth analysis across a number of contexts, which would inherently include some of these. But thanks for the question, Daniel. The only point I would make is, at a donor, based on any given nutrition advisor's portfolio, we will look, whatever portfolio we may cover will inherently include a whole bunch of different types of contexts, some of which will be particularly non-permissive or prone to constant service disruptions and conflict or what have you. All I will say is I think that this plays into what Chloe's talking about, her very first point about context dictating so much of cost analysis or cost effectiveness, that these things inherently, I think this is one of the real reasons to continue to push forward in this space, is to better understand the costs so that we're not trying to hold a South Sudan to the same standard as a Burkina Faso or something like this. Maybe that's a bad example contemporarily, but you get what I'm saying is we want to be able to better understand the disruptions that you're pointing out and how they affect cost. And I think that we have to get the nerds involved, like Caitlin and stuff, right, to really help us through this process, to know what those costs are and to better be able to put a number to them and kind of understand their size and scope. I don't know if somebody else wants to pick up on that.
I would love to jump in as well, Daniel. I think this is a great question and is one the IRC grapples with a lot, because we primarily focus on delivery in conflict and crisis environments. What's really interesting that has emerged so far from our data is how much, as I kind of mentioned in my presentation, the costs of these programs are kind of stuck on rails. You're going to keep paying your staff. If you possibly can, you're going to keep procuring RUTF. And then what we see in these programs is that when there's either a supply chain disruption or especially an access disruption due to security or population mobility, basically you have to keep paying most of those same costs. And then all of a sudden, the number of children you can treat just falls off a cliff. And so especially where we have long periods of observation in a particular country, we see really wide swings in cost efficiency, not actually because the costs are changing, simply because the number of children is changing really dramatically. And what's been interesting over time, and this is actually something that for us shows up not only in the nutrition space, but in any other kind of center-based programming that IRC does in a conflict or an insecure environment, is what's the ratio of time at which a program can be operational versus not, before actually we need to start considering alternative delivery approaches. CMAN, or anything that is kind of center-based, inherently has this very high proportion of fixed costs. It's like in the United States, when you talk about running a post office, you need a post office even if there's only 10 people in that town. And so I think in some cases, this has really pushed us also to start thinking about alternative service delivery approaches using community health workers or other things like that, where the costs are a bit more flexible. And therefore, when these events happen that disrupt, this is mostly on security, this does not address supply chain disruption. But when security is disrupted, you still have some capacity to deliver and your costs can flex more easily.
Can I make one other comment based on this question, because it brings up an interesting kind of point in how the system or the ecosystem sort of works. I think that particularly with the commodity disruption, the supply disruption, I think if we can continue to better understand this space, then we can also quantify the impact that a pipeline break, particularly for one of the two UN partners, for instance, may have on the overall treatment, the continuum of care. So we can actually quantify where if all of a sudden TSFP programs don't have supply to continue carrying out programs, then perhaps it takes some period of time to be able to utilize a single product in the interim. What impact does that have on the caseload and lengths of stay and the overall, all the different drivers that go into costing the program? So
actually, sorry, I don't mean to belabor this point. I just love this question. And to the earlier point of how do we use this data internally, the fact that we can quantify better what you think of as the losses in terms of like program capacity sitting idle is helping us actually go to our supply chain departments and say, we need to come up with better and more stable ways of like floating programs through these periods. And it's an additional investment. It's something that normally you would think, well, that's going to make it less efficient. I don't want to do that. But it's precisely the ability to show what's being lost when you have a program operating, you're paying for everything, and you can't get children in because you have no supply. And so having that evidence is helping us motivate folks who are normally pretty focused on the bottom line and trying to reduce costs to say, actually, we're losing because of this arrangement. We need to spend more to be more efficient.
Okay, great. Thanks so much, Eric and Caitlin. I think that was obviously a really great question and sparked a lot of great conversation. It would also be great, I think we have several questions from Dr. Nader in Syria, who has asked several questions, I think, of you, Eric. Perhaps if you want to clarify your questions or ask them yourself, it may be useful. Otherwise, I can ask them. You can come off mute and go ahead with your question for Eric. Otherwise, I can ask them for you.
Stacey, I just need to find the person and I will allow them to speak.
Oh, sorry, Ben. Okay.
But I can't.
It's,
if anyone can help me.
It's the first name in the participant list for me.
Oh, yes, it is me as well. Yeah, thank you.
Mm-hmm.
Okay, go ahead. Abu Lebdi.
Yes, can you hear me?
Yes, go ahead. Thank you.
Thank you very much. So my second question is for Eric. We know that BHA funding many UN organizations around the globe. One of them is Syria, and when we are reporting to them what kinds of data or assessment they're interested to see from the country offices regarding the cost effectiveness of the interventions, to see how their funds are utilized to reduce the burden of wasting. And a second sub-question is there a cost effectiveness threshold for cost per child? Over to you.
Yeah, so going back to Caitlin's presentation at the beginning, you saw how one organization has sort of taken on this challenge. I'm working backwards on your questions, by the way. So I'm looking at the threshold question first. And you saw the variability even within the list that she produced at IRC, and that's just whichever programs were able to submit sufficient data to, be part of that analysis. It's probably not even all of IRC's programs in this space, but even that, it's just one organization, and yet you still saw the variability. So when you ask about thresholds, the easiest answer is just a no. I think that this, my diffusion of innovation or whatever that bell curve, I really do think we're in this early stages of, especially at least as public health nutritionists, our economist friends better understand cost analyses, but we want to kind of control this dialogue, I suspect, so that it doesn't get overwhelmed with just pushing costs down and forget context and forget all the other important pieces of public health programming, right? And the integration with health and WASH programming and all the different impacts and effects that an economist couldn't be expected to know just coming in and looking specifically at costs. But I do think we can get there at some point where we begin to develop, even if it's just within a single organization. So an organization in a single country context can look across their programs across the different geographies within a country as we evolve and begin to say, all right, if we're able to operate at $250 per cured child in the majority of these cases, why is this particular location at $650 per child cured? I'm not in the weeds like some of my colleagues here on development of the tools and really deeply understanding the analysis. But what I'm looking at just as a donor in our position and trying to influence and create the correct incentives across this space is I just think that there's a little bit more sunlight on some of these issues, greater transparency is going to allow a whole set of like easy fixes that aren't going to, get at the really sophisticated changes. But if an organization just begins to see and understand this, they're going to be able to identify problem spots and different efficiencies that they can very easily pivot to and change. Maybe further down the road, greater changes will take place. But if we can just create a better understanding, I'm certain that a lot of the outlier, very expensive, very problematic programming can kind of start to get resolved. And then the question about what data is sought, I think it's also still too early. These aren't very good answers. It's also, I think, still too early. We are not prescribing at USAID BHA how an organization needs to provide information to us on cost effectiveness and cost analysis. We have developed a tool that we would like to see get more traffic, but it's not a perfect tool. None of them in the space, I don't think, are. There's some things that it does very, very well, and there's some things that you have to get pretty proficient in the space to be able to use quite well. And you might even have to use it in combination with another tool, right? So stay tuned. I mean, stay tuned to the space, I guess I would say, in terms of what data an organization should be collecting and looking at. But there, as of right now, in terms of official response, the USAID BHA is not requiring a specific set of costing information or costing analysis at like design or proposal stage. Over. Dr. Nader, I hope that was, if you could follow up or anything.
Yeah. Thank you very much, Eric. This is very comprehensive. So can I ask my other two questions, or is it okay for the panelists?
Stacy's our questions are. I defer to her.
Yeah, there's another question. There's another question is to calculate the cost effectiveness, is there a specific methods have been used, like a decision tree or Markov? And what are the variables are required to generate the model, if any? Thank you.
Yeah, I'm going to defer to other colleagues on that one.
If one of the panelists wants to take a question, maybe a bit quickly, we can jump on answering that one.
Stacey, I can take this. This is Chloe. I think there's, it depends on kind of what sort of analysis you're looking to do. You mentioned sort of Markov models and decision trees. I think those are helpful when you're using secondary data and you need to assess a range of potential, recovery rates or mortality rates, or even cost estimates, total cost or unit cost estimates, and see what the sensitivity of your outcomes, your analytical outcomes are to that. I find if you have program data, you can take your program cost and divide by the number of children enrolled or recovered to do a basic, to get, without doing any sort of confidence intervals, or probabilistic sensitivity analyses. If you just want to have a basic estimate, you can use that. Of course, this assumes that you have measured your, that you have a sort of M&E system measuring the number of kids enrolled and recovered, and that those numbers are reliable. For cost data, this is sort of what we're talking about. The devil is in the details. To calculate cost data, you can use as a starting point the accountancy for a program. Some of those costs would need to be removed, any cost related to research. You might want to include other costs. We've heard here time and again that oftentimes RUTF is, or any kind of product used is not included due to those costs being covered by other partners. So this is where I think some of the future webinars in this series will help inform some of the nuances of how best to collect good quality cost data. But I would say at a minimum, mention what has been included in your cost estimates, and report your total cost and divide by the outcomes that you have, and that will get you started. The models are more, I guess, for if you want to publish or look at sensitivity or do a secondary data analysis. Over.
Yeah, and Chloe, in response to this too, like part of this is just creating a budget, right? Like some of this is being done on the back of the napkin sort of a way anyway, right? Like as you go through thinking about what you're going to ask the donor for to fund your program, you're doing this exercise, albeit, often imprecisely. And I think what we as a community got to get better at is going back then and, verifying how effective those estimates were and what other costs were borne out through the execution of the program to start to better understand it.
Exactly. And one thing I will say to that is that when looking at the cost for a study, oftentimes a really useful exercise is to go to like the research staff and ask them, okay, you were hired to do research. That was your job description. How much implementation did you actually do? Like any other staff that may have been hired to do other things, but could be pulled in when additional staff support is needed, because you'll often find that the staffing, for example, has been under budgeted. And so sort of ancillary staff are brought in during peak times. And, if you look at all the cost related to implementation as it was implemented, even retrospectively, you'll find things that were not anticipated. Over.
Okay, thank you very much, Chloe. And thank you very much for being patient with me. One last question, please. So when calculating the cost of implementation, is there a design tool that can make the cost effectiveness exercise easier? Over to you, and thank you very much.
Is there anyone else who wants to take this? I'm not sure about the tools. I know that Lonnie and Eric have mentioned tools that have been used. I tend to do my estimates in probably a more involved way.
Yeah, Kathleen, if I may respond, basically, we use the Fanta tools that been available online, and then it's been contextualized, right? Like I said before, like in Indonesia context, like we adjusted with the Ministry of Health IMAM guideline that just been released in 2019, which consists of the prevention and then the outpatient, inpatient. So those kind of components, including like adjusted in terms of, the essential medicines that being used in Indonesia, this is something to be considered. So that's why maybe going back to the detail of cost of drivers, when we decided which kind of component, it's really need to be discussed with the governments on what kind of, component to be included in that analysis. So toward the end, when we receive the total envelope, it basically come from, different kind of component and drivers that has been agreed upon, and then we all clear about that definition of operational. So I think, yeah, it's going back, like each country will determine, basically, it's like we see from Bernadette and also Kathleen presentation also that basically it's very much depend on the context and what component to be included, including like the RUTF itself. Thank you.
Yeah, and I'll just point out that the facet for SNF tool that we talked about does a very thorough job of looking at the costs incurred by way of products, where it's you can select sourcing it from different locations, the inherent shipping, storage, warehousing costs. It allows you, it walks you through product loss. It also very adeptly builds in and allows you to manipulate recovery rates and coverage for your program, et cetera. What Blandina just talked about with the Fanta set of tools really parses out the programming aspects, and that's something something the Facet for SNF tool did not take on specifically. So there's basically a single field to enter your programming costs, and to an audience of nutrition programming people, you probably think that that's way too simplified. And it probably is, but if you generate that number elsewhere and bring that into the single field into Facet, then that tool can be helpful for the question you asked, Dr. Nader.
Thanks so much for those interesting questions. I think we're perhaps running out of time for the Q&A portion, but if we have a chance for just maybe one quick response on one that has already been briefly answered in the Q&A by Caitlin in writing. I was hoping perhaps another panelist might jump in and give another perspective on it. It was asked by Andrew Seal around looking at these cost efficiency analyses, doing the cost effectiveness analysis, or so the question is, sorry, do we have any cost effectiveness analyses that look at deaths averted or other health outcomes? So Caitlin has already taken the first stab at it, but she mentioned that others may have, other panelists may want to also jump in. Perhaps Chloe or Blandina, if you've looked at deaths averted.
Yeah, thank you, Stacy. Basically, to be honest, in Indonesia, we still in the process of doing cost efficiency, not cost effectiveness, because we still have a challenging in terms of the data on number of children receive treatment, and then what is the quality nationally. We haven't got the data yet. So in this sense, basically, maybe other panelists would be suitable to answer that question, because we haven't done the cost effectiveness yet. Thank you.
I can say from my perspective, I think Andy would be just as familiar with the studies that have been published. Often from what I know of the literature, we do not see large enough sample sizes to really say a lot about deaths averted. I know in the Bangladesh study we published several years ago, we were able to say something, but it was very, very high, very low cost effectiveness, I would say, very high cost per death averted, just due to small sample size and there being a very low number of deaths. But in general, we might see, in fact, much higher, much better cost effectiveness, but the coverage of the program and maybe the duration of the analysis would have to be quite long. That's my thought there. I don't know about other health outcomes. I'm not sure about that, what that question is getting at, but I'm happy to answer further if you need.
Thanks, Chloe. I think that was quite similar to the response that Caitlin gave as well, in terms of needing a larger sample size and the like. So I think we are running a bit out of time on the Q&A session, and we do have a few other things that we want to get to, including the poll that you can see is about to get started. But we will post all the Q&As and make them available to all the participants, and we will go ahead and answer any of the unanswered questions when doing so as well. I'm going to hand it back over to Bernie now, I think, for the poll and some other additional topics.
Thank you very much to all of the speakers and all of the panelists for answering questions and your brilliant presentations. You will see on your screen now, there is a poll. If you could answer that, that would be brilliant. Basically, we have mentioned that we will be carrying out a series of webinars, quarterly webinars over the next year or so. And while we do have some ideas, we would love to have your input on what you would find most useful. So please pick an answer. And I can see the answers coming in. That is great. There will also be another chance for an open-ended question right at the end of the webinar. Right, so we will leave the poll open for a little while to give you all a chance to answer. And while we do that, we'll hand over to Ben, who will say a few words on the GNC Technical Alliance.
Thanks very much, Bernadette. Whilst you're sorting out the video, I'll just introduce myself quickly. I'm Ben Allen, and I am the Deputy Coordinator of the Technical Support Team, part of the GNC Technical Alliance. And before I just give some very brief words on the kind of services that we provide, Bernie is going to play a video, which is only 2.5 minutes long.
Just 1 second, Ben, whilst I work out some technical issues.
Okay. Well, what? Like,
sorry.
It's okay.
Oh. Okay, I might have to end. Right. Almost there.
There are many events that can throw a country into crisis. Disease outbreaks, natural hazards, or conflicts. Most crises will affect all areas of daily life. Accessing support should be easy, especially for something as essential as nutrition. For this purpose, the Global Nutrition Cluster Technical Alliance was developed. Whenever nutrition is at risk, we help to identify the problems that are stopping or slowing down progress. And together, we will work on technical solutions. So, let's say you work in the field of nutrition and are facing an emergency that you either have to prepare for, recover from, or react to, and you need support. Contact us. Scroll down to the request form, ask a question, or describe the challenge you are facing. We will look at your request, and together we will work out what is needed and ensure that this support reaches you as quickly as possible. This might be providing up-to-date guidance and advice on how to apply it to your specific context. In-depth technical support, where we work together to find the technical resources that are needed, or recommending technically vetted external consultants. This technical guidance covers well-known situations. But what happens when something new or unknown comes along? Our global thematic working groups quickly provide interim guidance or resources when there is no specific guidance yet, as with a new disease, new scientific knowledge, or when experts disagree. So, how much does our support cost? Well, some help is free, some is not. But we will work with you to find a cost option that meets your needs. Our alliance aims to use local capacity. If that capacity is not available, we will work with you to build it. And only as a last resort will we use regional or global resources. If you ever have to deal with a nutrition emergency, please let us know. We are here for you.
Thank you, Bernie. And so just in a couple of minutes, I'm going to focus on the support that the technical support team can provide. And this is available very easily for any type of organization, for any request for technical support in nutrition in emergencies, however small or large. And you can lodge that via our website, as explained in the video. Just look either on the GNC website or on the GNC Technical Alliance website. Just look out for that big orange button. And we provide 3 different types of service. Either help desk support, so quick responses to small questions, reference to particular guidance, things that might take around a day or 2 of one person's time or lower. So we have a team dedicated to that. We also have individuals and consultants and partners who are available to provide in-depth support to countries via advisors, either deployed in country or remote support. And finally, we also have a roster of consultants. So if you just want to recruit a consultant for a long-term piece of work, or perhaps you want to references for profiles for a particular position that you have vacant, we have a roster of consultants of about 200 consultants with IYCFE, CMAM, SBC, assessment, and other NIE expertise. So we can do that as well. And next slide, please, Bernie. As mentioned by me already twice, and the video, there's the website, there's the orange button, and Bernie, if you click on one, you can have a look at how simple the form is. So whether you might have a clear understanding of the support you want, you might not. It doesn't matter. So just lodge your request there, and then someone will get back to you within 72 hours. And that's all. Thank you very much, Bernie.
Great. Thank you, Ben. So the last thing I wanted to mention is that, well, as I said earlier, one of the objectives for our costing and cost effectiveness working group is to be able to share information on available tools, guidance, and evidence. So we have recently set up a web page on the State of Acute Malnutrition website, which you can see here. So this is very much under construction, and we'll start adding resources to it as the work of the group progresses. We're also working with ENN to set up a forum, so you can stay in touch via that. If you have any questions, there'll be a couple of moderators and members of the group who hopefully will be able to answer that. That forum is not live yet, but it will hopefully be there in the next couple of weeks or so, and we will be adding a link to that on the web page as well. And that's it from us. So thanks again to all of the speakers and all of you for participating. As you leave the webinar, there will be an evaluation popping up. Please do fill that out, and it's very useful for the GNC TA to have feedback on the webinars. All right, so we'll hope to see you in future webinars or on the ENN forum. Thank you very much.
Thank you.